Welcome to this explainer on the principles of clinical wound management and healing phases. Mastering these timelines isn't just to pass your boards. It's absolutely crucial for how we optimize recovery on the wards. All right, let's drop right into this rapid-fire clinical review.
Section 1. Debridement and soft tissue.
Question 1. Non-selective debridement, for example, using irrigation and wet-to-dry dressings, is known as which of the following? A. Surgical. B. Autolytic. C. Biological. D. Enzymatic. E. Mechanical.
Okay, the correct answer is E. Let's dive into this exam, Pearl. You've got to notice the precise distinctions here. Surgical debridement relies on actual excision down to healthy bleeding tissue. Mechanical? That's your non-selective removal via irrigation or wet-to-dry dressings. Autolytic literally uses the body's own endogenous enzymes under moist dressings, while enzymatic applies a topical chemical for liquefaction. And finally, biological uses maggot therapy for highly selective debridement.
Question 2. A 27-year-old presents with skin and subcutaneous separation from fascia, with the fascia intact. What is the correct classification? A. Limited. B. Non-circumferential. C. Circumferential single plane. D. Circumferential multiplanar. E. Mangled limb.
The correct answer is B. Here's a really crucial clinical pearl for you. The true culprit in degloving is the shearing force. That force separates skin and fat right off the fascia, literally severing the perforating blood vessels. Now, limited affects small areas, non-circumferential is your single plane undermining, circumferential wraps the entire limb, and multiplanar, that penetrates way down into deeper tissue.
Section 2. Healing and vascular response.
Question 3. Which tissue heals without scar formation? A. Liver. B. Skin. C. Bone. D. Muscle. E. Heart.
The correct answer is C. Now, what's really interesting about this is that bone heals by true regeneration, not fibrotic repair. That means it leaves absolutely no scar. The progression is highly structured, moving from a hematoma to a soft callus, then hardening into woven bone, and finally remodeling into perfectly structured lamellar bone.
Question 4. Which is true regarding vascular response? A. Vasoconstriction is an early response. B. Vasodilation is detrimental. C. Vascular permeability is maintained. D. Histamine and PGE2 cause vasoconstriction. E. Histamine has no role.
So the correct answer is A. Let's unpack this vascular pearl real quick. Your immediate, literal first response to stop blood loss is vasoconstriction, and that's mediated by reflex neurogenic signals and endothelin. Conversely, the vasodilation that happens right after is driven by histamine and prostaglandins.
Section 3. Hemostasis and mediators.
Question 5. What is an early step in small vessel hemostasis? A. Fibrin deposition. B. Vasoconstriction. C. Activation of platelet factors. D. Activation of clotting factors. E. Platelet plug formation.
The correct answer is B. So the crucial point here is the strict sequence of hemostasis. It's step 1, immediate vasoconstriction. Step 2, platelet adhesion and aggregation to form the initial plug. And step 3, the coagulation cascade kicks in and locks it all down with a super stable fibrin clot.
Question 6. What is the effect of nitric oxide? A. Enhances vascular permeability. B. Increases chemotaxis. C. Increases leukocyte adhesion. D. Vascular smooth muscle relaxation. E. Increases chemotaxis.
And the correct answer is D. Here is your pearl for this one. Nitric oxide has a brilliant dual role. On one hand, it causes vasodilation via smooth muscle relaxation to increase blood flow. But it also serves as a potent microbicidal weapon inside macrophages to fight off wound infection. It's a real multitasker.
Section 4. Cellular milestones and timelines.
Question 7. Collagen is produced by which cells? A. Monocytes. B. Macrophages. C. Fibroblasts. D. Endothelial cells. E. Neutrophils. The correct answer is C. And this brilliantly illustrates the contrast between two major cellular players. Think of fibroblasts as your builders. They synthesize the collagen structure. Macrophages, on the other hand, are your site managers. They regulate the overall healing process by releasing growth factors like TGF-beta and PDGF.
Question 8. Time for re-epithelialization in surgical wounds. A. 24 hours. B. 48 hours. C. 72 hours. D. 96 hours. E. None.
The correct answer is B, 48 hours. The clinical pearl you absolutely need to remember here. Primary closure wounds rapidly re-epithelialize in just 48 hours. Wounds left to heal by secondary intention take drastically longer, simply because they must first fill with an entire bed of granulation tissue.
Question 9. Fibroblasts peak after injury at A. 2 days, B. 5 days, C. 10 days, D. 14 days, E. 21 days.
The correct answer is B, 5 days. Let's move to and see how this builds, because this cellular timeline is key. Neutrophils, they are the first responders, arriving right at day 2. Macrophages take over the scene at day 3. Then fibroblasts hit their peak proliferation to rebuild tissue at day 5, and finally, lymphocytes arrive at day 7.
Question 10. Inflammatory phase ends maximally after A. 1 day, B. 4 days, C. 7 days, D. 14 days, E. 21 days.
The correct answer is B, 4 days. All right, let's summarize the ultimate healing timeline here. The inflammatory phase sparks from days 1 through 4. Then, proliferation builds from days 3 to 21. Finally, remodeling refines the tissue over weeks to months, maximizing tensile strength right around 12 weeks. When you step back and look at this timeline, the question isn't just how the body heals, but how can our modern clinical interventions accelerate these already perfectly sequenced biological clocks? Thanks for joining this explainer, keep studying, and we'll see you next time.